Assessing and managing various risks is a core task and legitimate expectation of mental health services. Various risks involving people who experience mental illness can be identified. The risk of mental health service users perpetuating violence towards others attracts the most public attention. There is also widespread awareness of the risk of suicide among people experiencing mental illness. The risk of self-neglect as a result of mental illness is probably far more common, but receives significantly less attention in the media. Similarly, there is very little public attention given to the risk of iatrogenic effects, which is harm caused by the health services to people who use them, regarding mental health intervention on persons served, or the risk of people who experience mental illness being harmed, abused, or exploited by others. Yet these are risks which also require addressing. In the field of mental health, risk is, of course, a highly emotional term, which tends to automatically be associated with harm. The expectation generated is that harm will be eliminated. However, in other arenas, risk has more positive connotations. In business in particular, there is an acceptance of the benefits to be gained by taking appropriate risk. Recent authors on risk in mental health have sought to readdress the totally negative perceptions of risk, highlighting the need for clinicians to be empowered to take appropriate risks for the longer-term benefit of their clients. This lesson on risk management involves watching this video and also watching the Stanley Brown Safety Plan webinar, which is provided by the Substance Abuse and Mental Health Services Administration. After completing all aspects of this lesson, you are required to complete the attached quiz with a passing score of at least 70% in order to successfully complete this lesson. It is useful to begin with the definition of some terms. Risk is the likelihood of an adverse event or outcome. Risk factors are the particular features of an illness, behavior, or circumstances that alone or in combination lead to an increased risk. Risk assessment is an estimation of the likelihood of a particular adverse event occurring under particular circumstances within a specified period of time. And finally, risk management aims to minimize the likelihood of adverse effects within the context of the overall management of an individual to achieve the best possible outcome and deliver safe, appropriate, effective care. Although useful, these definitions exemplify a common approach to the issue of risk in mental health in conceptualizing risk as entirely negative. Risk is limited to the likelihood of harm. It excludes the likelihood of benefit. This usage has had a dramatic, substantially negative effect on the debate about risk-taking in mental health services. If risk only concerns the chance of harm, then the objective must be to eliminate it. But a moment's thought reveals that that is impossible. An alternative definition of risk might be the likelihood of an event happening with potentially harmful or beneficial outcomes for self and others. The objective in addressing issues of risk is to work with the person served toward achieving the best possible outcomes for themselves and for others whom they come into contact with. Apparently, separate processes of risk assessment and management are often identified. Relevant literature and policy statements tend to explore assessment in far more detail than management. In reality, risk assessment and management is an ongoing, dynamic, and interactive process. Further, the only value of risk assessment is in informing providers in terms of a management strategy. There has to be a point where the payoff from obtaining more information about risk factors has little additional value in terms of risk assessment and management. There may be too great an assumption that the most appropriate place for investing more time and energy is in more and better risk assessment rather than in better risk management. Nevertheless, the distinction between risk assessment and management is useful to clinicians to identify specific information that needs to be gathered and evaluated, both during initial contact with persons served and on an ongoing basis. There are a number of specific risks that need to be identified and addressed in mental health practice. These can be usefully categorized as risks of harm to persons served and risks to other people that may be posed by the individual's illness or behavior. Risks to persons served include safety, suicide, or deliberate self-harm, health, progression of the illness, psychological and or physical harm, and drug or alcohol abuse, self-neglect, and vulnerability to exploitation, abuse, and violence with others. Risks to others include violence, including physical, emotional, and sexual violence that is perpetrated by the person served toward others, intimidation and threats, abuse or neglect of dependents, especially children, property damage, and public nuisance or reckless behavior, including dangerous driving. A range of factors that need to be evaluated and considered in completing a risk assessment have been identified in the literature. These can be summarized into a thorough mental status examination, particularly assessing the client's behavior, including dangerousness or threatening actions, affect, including low or elevated mood, suspiciousness, hostility or anger, cognitions, including thoughts of self-harm or harm to others, and delusional beliefs, particularly related to being threatened or loss of self-control, and any abnormalities of perception, especially considering command hallucinations. It is also essential to assess the client's life functioning and self-care. Also to be evaluated is the individual's current social and environmental factors, including accommodations and social situation, relationships, the availability of support for the individual, threats from others, losses and or specific stresses, arrest or criminal charges, substance abuse, access to means of harming oneself, and cooperation with treatment. Additionally, historical information, including previous patterns of illness and behavior and previous risk events, should also be evaluated. It is also important to examine positive potentials and resources that might be available to the person served. Ultimately, risk management will be dependent on the availability of resources. In addition to the availability of resources within the mental health services, it is vitally important to investigate what resources are available to or through the person served, their significant others who provide support for them, and other social supports, as well as the broader community. Sources of information for risk assessment include the interview and observation of the person served, other informants such as family, friends, and work colleagues, and previous records, Great weight should be given to information and opinion gained from those who know the individual well, whether they are family, friends, or staff. It is particularly important to clearly identify early warning signs of the development of risk in the mental status or behavior. In recent years, some emphasis has been given to the use of actuarial instruments for assessing risk. These devices identify specific factors that are often associated with specific risk, such as a risk of violent behavior. They can be used to derive a summation of risk factors that an individual has. The temptation can be to use such devices to calculate some form of risk score. However, actuarial tests are able to identify high-risk groups. Extreme caution is required when applying the probabilities derived from actuarial methods to individuals. Especially significant is the possibility for false positive identification of risk and coercive interventions based on this. Adverse outcomes to risk decisions invariably result in inquiries. However, the more common false positive assessments are not subject to such scrutiny. There are several steps in the process of risk management. First, as part of the risk assessment, we need to identify and document the individual risk factors. Second, develop a risk management plan, which is based on our understanding of the formulation of risk. Third, communicate about the plan in consultation with the person served and his or her family or caregivers. This includes written and verbal communication and includes communication between individual providers, teams, services, other agencies, families, and individuals. Fourth, we need to act in accordance with the plan, again in consultation with the consumer and family members or caregivers, including monitoring and treatment. Fifth, we need to evaluate the outcomes of the plan. And finally, we need to review the plan in consultation with the consumer and family or caregivers. Appropriate communication of information is a key element of risk management that has been complicated and hampered by inappropriate understanding of the principles of confidentiality. Client confidentiality is indeed an essential element of all health services. However, confidentiality must be secondary to safety. Confidentiality laws allow for the disclosure of relevant information where this is necessary to prevent or lessen a serious threat to public health or safety, or to the life or health of the individual or another individual. When we begin to consider risk management within a recovery-oriented system of care, 6 principles seem to apply. First, we need to focus on individual strengths rather than pathology. There is a particular caution against an overemphasis on diagnosis at the expense of a specific understanding of the individual client. It is the individual's strengths that provide the vital resources for recovery, including self-management of their own risk factors. Second, the case manager-person served relationship is primary and essential. An effective therapeutic relationship ensures that informed help is readily available and accessible, especially at times of crisis. Specifically in regard to the risk of violence, it could be said that in the long run, maintaining a therapeutic alliance, particularly with difficult and objectionable patients, which promotes treatment compliance and maintains the necessary social and interpersonal supports, is a greater contribution to reducing violence than the finest skills in risk assessment. Third, interventions are based on the principle of self-determination. This is concerned with maximizing the power of persons served and their family members in decision-making concerning their lives. Ultimately, the best long-term protection is an individual who is competent and empowered to make decisions to minimize their own risks. Fourth, assertive outreach is the preferred mode of intervention. Service delivery in the community promotes better engagement with clients and is likely to also facilitate a better understanding of the context in which the risk factors occur. Fifth, people with long-term and severe mental health problems can continue to learn, grow, and change, and they can be assisted to do so. Change is inevitable. Risk is therefore not static but fluid, and assessment and management of risk must be responsive to change. The task of case management is to ensure that as far as possible, the changes that do occur are positive and result in a reduction in risk. It is also important to ensure that clients are not bound by outdated assessments of high risk. And finally, resource acquisition goes beyond traditional mental health services and actively mobilizes resources from the entire community. Positive community connection is likely to decrease any elements of risk. There are a number of principles of best practice for risk assessment and safety planning that are consistent with recovery-based care. First, service users should be active participants in their assessment and safety planning process. A key component of a recovery-oriented approach is the involvement of persons served in constructing their personal care and safety plan. Engagement of the person served and input is critical if the risk assessment and safety plan is to be person-centered. Involvement of the person served ensures a more accurate assessment of risks and vulnerabilities, better understanding of that person's perspectives on risk and safety, and greater ownership of the process and the service plan. Full engagement is not always possible, and staff may be required to make decisions around safety for the person served, especially if they are in the early phase of their recovery and are acutely ill. At these times, it may be unhelpful and unrealistic to have expectations of the person served that they cannot meet. In such an event, this should be documented and every effort made to re-engage the person in collaborative dialogue as soon as possible. In addition, it is essential that the provider continues to treat the person with dignity and respect, keeps the person fully informed, and conveys an expectation of future involvement and recovery. Research indicates that many persons served are not aware that their risk is being assessed, managed, and documented, while others report that they are aware of the fact that the professional is forming an opinion about their illness and level of risk without their involvement. The language used to discuss risk with persons served is also important, as language often influences thinking and subsequent action. While the language of risk and risk management dominates the policy and clinical practice culture, risk language may alienate persons served as they prefer to speak of personal safety and ways of keeping and promoting their safety. The second principle is that a trusting relationship between the person served and all those involved in providing their care is the best foundation for effective care and safety planning. Risk assessment and safety planning is a relational process that is rooted in the therapeutic dialogue and involves getting to know the individual rather than a process of procedures and checklists. It is also a process which requires the provider to engage with the person while working within best practice parameters and policies. A helping relationship is built with care, compassion, and respect. Each therapeutic relationship is unique and may be influenced by many different factors. Every interaction with the person served is an opportunity for the provider to undertake risk assessment and safety planning by engaging into a supportive relationship and offering help to reduce the person's distress at that time. The process of engagement in risk assessment and safety planning has the potential to enable the person and the provider to feel a sense of connection, create a space for exploration and further understanding of distress, and open a space for dialogue and reflection on possible options and solutions for positive risk-taking. Conducting risk assessment and safety planning with the person served requires the provider to be able to connect with the person and demonstrate a willingness and ability to develop and remain connected with the person while recognizing there are no certainties or guarantees. The third principle is that a comprehensive risk assessment requires a non-judgmental and positive attitude toward the person served. Engaging in a discussion about risk with persons served can be experienced by providers and those individuals as challenging and anxiety-provoking. Such responses can impact on how providers relate to the person served and have the potential to hinder the development of a trusting, working relationship. Attitudes held by providers toward persons served who are at risk, together with their knowledge, skill, and sensitivity, are likely to influence their working relationship and hence the experiences and outcomes of a comprehensive risk assessment. Staff with negative attitudes may find it difficult to respond with hope and in a helpful, compassionate, and creative way. Each person's experience of recovery and risk is unique and will reflect in any given moment their experience of themselves and their world. Conducting a risk assessment is therefore different with each person and will vary according to the context of the interaction and the nature of the relationship. Nevertheless, all risk assessment interaction need to be based on a model of respect and facilitation as opposed to asking a series of standardized, impersonal questions, often in the format of a checklist. Principle number 4 states that a risk assessment is an integral part of the person's overall mental health assessment and recovery plan. Risk assessment and safety planning does not take place in isolation, but is part of the person's overall assessment and recovery or service plan. The safety plan developed as an outcome of the risk assessment process should be aligned closely with the broader context of the person's wellness and recovery, being mindful of the interrelationship between risk, personal learning, and ongoing recovery. This will help integrate and support continuity of care, which is essential for effective risk and safety planning. Principle 5 states that structured clinical judgment is considered the best approach toward risk assessment. The reason for conducting a collaborative risk assessment is to gather information to form an overall picture of the person, to place the person on a continuum of risk, and to inform a plan to support the person and the provider in maintaining safety and to promote the potential and priorities of the person served. There are 3 main approaches to the assessment of risk in clinical practice. The first is unstructured clinical judgment, which relies upon intuition to carry out an assessment. Actuarial methods, which use empirically validated tools and instruments to measure risk. And finally, structured clinical judgment. Structured clinical judgment uses a combination of clinical judgment and actuarial methods, tools, checklists, to assess the individual's risk and is considered the best approach toward risk assessment. Structured clinical judgment takes the form of engaging with the person to explore risk as well as protective factors and includes multiple perspectives, such as the person's, the family's, other providers, and other individuals involved in the person's life. Principle 6 states that risk assessment and safety planning should adopt a strengths-based approach and acknowledge protective factors. Risk assessment and safety planning must be built on the recognition of the person's strengths. The identification of protective factors is integral to a strengths-based approach to risk assessment and safety planning. Protective factors are personal strengths, skills, and resources available to the person that they can use or be supported to use as part of their service and safety plan. Protective factors can arise from within the person, from their support networks, and their environmental context. Protective factors may be identified by the individual themselves or through collaborative dialogue with their mental health team, their family members, or others. It is only through a comprehensive assessment of the person's protective factors or strengths may the person be encouraged to go on and take positive risk. In taking a strengths-based approach toward risk assessment and safety planning, providers may reflect upon the person's past achievements and coping mechanisms and explore with the person how he or she can best make progress with the use of current resources, support structures, and personal strengths that are available at a particular point in time. The seventh principle is that therapeutic or positive risk should underpin risk assessment and safety planning processes. Positive risk is about weighing the potential benefits and harms of exercising one choice of action over another, identifying the potential risks involved, and developing plans and actions that reflect the positive potential and stated priorities of the person served. It involves using available resources and support to achieve the desired outcomes and to minimize the potential harmful outcomes. In the context of recovery-oriented practice, therapeutic or positive risk is a process which promotes the self-determination, autonomy, and freedom of the person served, while taking into account the safety needs of everyone involved. No action is entirely free of risk. Positive risk-taking acknowledges the inherent risk of all options and seeks to choose risks which will support the person's autonomy and life goals. The goal of eliminating all harmful risks is both damaging and an illusion, and can be unintentionally counterproductive by reducing skills in risk self-management and reducing the extent to which people develop skills at taking responsibility for their own actions. The role of the provider is to engage and work with the risk in ways that balance risks with opportunity for personal development and learning, while minimizing harmful consequences. As the promotion of recovery inherently rests upon an individual's ability to act, think, and advocate for themselves in a positive capacity, recovery and therapeutic or positive risk-taking go hand in hand with a recovery-based approach to risk assessment and safety planning. Principle 8 states that a comprehensive assessment of risk includes consideration of risk posed by the person served to themselves and others, as well as risks posed to persons served by others, and iatrogenic risks. Risk in mental health service provision is an inherently broad topic, both in terms of who the risk is perceived to be directed toward and the types of risks that are deemed worthy of assessment and management. Stakeholders in the provision of mental health services have been found to focus almost entirely on the risks posed by service users to themselves and others, while mostly ignoring the risk posed to service users by others or by the mental health services that they use. In a recent study exploring the practices, policies, and processes around risk and safety management within mental health services, risks to self by either suicide or self-harm, and risks to others by violence were disproportionately emphasized. In order to capture a balanced and comprehensive assessment of risk, assessment should include consideration of risk posed to the person served to themselves, risk posed by the person served to others, risk posed by others to the person served, and iatrogenic risks, or risks posed to persons served as a result of their engagement within the mental health system. Principle 9 states that a risk assessment and safety plan must include a consideration of the risk factors. A number of risk factors may impact on the person's safety, including personal, organizational, and relational factors. Risk assessment practices in mental health often overplay personal risk factors at the expense of organizational and relational factors. Careful exploration of all risk factors in the context of protective factors can be helpful in determining with the person served the level of risk they present. Personal factors are focused on the person and are frequently classified as either static or dynamic. Static risk factors, otherwise known as non-modifiable risk factors, are risk factors which are unlikely to change in a person's life. Demographic status, aspects of one's personal history, personality attributes, socioeconomic factors, early onset risk factors, and comorbid substance abuse are largely unchanging aspects of a person's past or present life, which may increase their risk of running into negative outcomes. Dynamic factors, otherwise known as modifiable risk factors, capture the fluctuating nature of the person's environment and internal capacity to manage risk. They fluctuate in intensity and severity and are amenable to change. Such factors include situational triggers relevant to a person's life, social factors, a sudden or gradual deterioration of the person's mental state, reoccurrence of previous trigger circumstances, poor treatment adherence, and disengagement with therapeutic alliance or services. Dynamic factors are highly contextual and must be considered in light of the broader context of a person's current life, social ties, access to resources, and past experiences. Organizational or environmental factors are those that relate to the wider context in which care is being delivered, such as inconsistent or inequitable approaches to care and safety planning, policies and practices that discourage individuality, collaboration, and risk-taking, and the availability, accessibility, and acceptability of support and care options within and outside of services. Relational factors are embedded within the client-provider relationship and may manifest in the following manner: lack of skill and knowledge of staff, negative attitudes of staff, or staff overreacting to their own fears, inconsistent expectations and practices of practitioners, and authoritarian or dismissive approaches toward safety planning. Principle 10 states that risk assessment is only effective if it is followed with a safety plan. A risk assessment is only as good as the safety plan that is formulated as an outcome of the assessment process. Research indicates that there is often a disconnection between the risk assessment process and the development of a safety plan. Despite risk assessments being completed by providers, the safety planning step was often omitted, or the strategies identified to support the person's safety did not correspond with the risk identified. The development of a safety plan following the identification of risk is a critical step in meeting the objective of supporting the person and the provider to maintain safety, while promoting the potential and priorities of the person served. Once the crisis has resolved, the provider, in collaboration with the person served, should develop an advanced crisis or safety plan for the future. In the event of the person experiencing a future crisis, having a crisis plan that identifies strategies, including who to contact or who not to contact, can be of significant benefit to the person and others. Principle number 11 states that safety plans involve developing flexible strategies aimed at promoting positive risk, preventing negative events, or if this is not possible, minimizing the harm caused. A safety plan should aim to capture a summary of the risks identified, formulations of the situation in which identified risks may occur, including warning signs, factors that may escalate the risk, and strategies to be taken by practitioners and the person served in response to the risks identified. The strategies identified should be aimed at promoting positive or therapeutic risk-taking, preventing negative events from occurring, or if this is not possible, minimizing the harm caused. In addition, safety plans should endeavor to identify the potential benefits and drawbacks of choosing one action over another, with all actions being ultimately directed toward an individual's recovery. Safety plans should also include a clear statement of who is responsible for carrying out specific tasks in the plan. Ideally, a timeline for the review and possible reassessment should be constructed in advance and laid out in the safety plan. In addition to mapping future review timelines, safety plans should detail who on the team will carry out the review and/or the reassessment. Persons served should have a copy of their safety plan and be asked to indicate their agreement with the plan. Principle 12 states, to enable effective communication, the safety plan needs to be clearly documented. Documenting the risk assessment process and the safety plan is important for continuity of care and communication with the team and the person served. At all times, documentation should be available to the person served. Documentation is also part of professional accountability and provides information to enable providers to record interventions, note changes in the level of risk or protective factor, and provides information for ongoing review. In the event of a subsequent crisis or readmission to service, documentation helps by identifying effective and non-effective interventions or other influencing factors that were considered important. Documentation is also required in any review process and in the event of a negative outcome for the person served or for another person. Since we've talked about the importance of developing a safety plan, I want to introduce you to one of the most widely used and best known safety planning processes, the Stanley Brown Safety Plan. Rather than me talking to you about this plan, this lesson includes a webinar sponsored by the Substance Abuse and Mental Health Services Administration, where doctors Stanley and Brown, the developers of this process, present their safety plan. In the lesson media of this lesson are 4 documents regarding the Stanley Brown safety plan. The first is an instruction sheet on how to access and view the webinar with Drs. Stanley and Brown. This lesson requires that you view this webinar as part of this lesson. The next 2 documents are for your convenience. They are the PowerPoint slides of the webinar and the transcript of the webinar. And the 4th document is the actual template for the Stanley Brown safety plan. I want to end this lesson with a brief discussion of positive risk management. Decisions about risk management involve improving the person served quality of life and plans for recovery, while remaining aware of the safety needs of the person served, their family, and the public. Positive risk management as part of a carefully constructed plan is a desirable competence for all mental health practitioners and will make risk management more effective. Positive risk management can be developed by using a collaborative approach. Over-defensive practice is a bad practice. Avoiding all possible risks is not good for the service user or society in the long term and can be counterproductive, creating more problems than it solves. Any risk-related decision is likely to be acceptable if it conforms with relevant guidelines, it is based on the best information available, it is documented, and the relevant people are informed. As long as the decision is based on the best evidence, information, and clinical judgment available, it will be the best decision that can be made at the time. However, given the nature of severe mental illness, there will always be circumstances in which decisions about the care plan are going to be dominated by immediate concerns about the safety of the persons served and others. Lack of insight and non-adherence to treatment plans that have been put in place to reduce symptoms are particularly challenging aspects of the relationship between the person served and the practitioner. Symptoms can seriously impact on the person's ability to critically assess the implications of some of their actions, and this can result in unpredictable and potentially dangerous behaviors. In these situations, practitioners sometimes have to make decisions on behalf of the person served with their best interest in mind. A collaborative approach based on the principles of positive risk management is still the aim, but clearly this will require special efforts in these situations. Positive risk management means being aware that risk can never be completely eliminated. Therefore, management plans inevitably have to include decisions that carry some risk. This should be explicit in the decision-making process and should be discussed openly with the person served. Positive risk management includes working with the person served to identify what is likely to work and what is not, paying attention to the views of family members and others around the person served when finally deciding upon a plan of action, weighing the potential costs and benefits of choosing one action over another, being willing to make a decision that involves an element of risk because the potential positive benefits outweigh the risk, developing plans and actions that support the potential and priorities stated by the person served, and minimizing the risk to the person served or others. Being clear to all involved about the potential benefits and the potential risks, and finally, ensuring that the person served, family members, and others who might be affected are fully informed of the decision, the reasons for it, and the associated plans. Another way of thinking about good decision making is to see it as supported decision making. The governing principle behind good approaches to choice and risk is that people have the right to live their lives to the fullest, as long as that does not stop others from doing the same. Fear of supporting people to take reasonable risks in their daily lives can prevent them from doing the things that most people take for granted. What needs to be considered is the consequence of an action and the likelihood of any harm from it. By taking account of the benefits in terms of independence, well-being, and choice, it should be possible for a person to have a service plan which enables them to manage identified risk and to live their lives in ways that best suit them. This completes our presentation on risk management. Please remember that this lesson includes your watching the Smith-Brown Safety Plan webinar, with information on how to view this webinar located in the Lesson Media section of this lesson. When you have completed all parts of this lesson, you are required to complete the attached quiz with a passing score of at least 70% in order to successfully complete this lesson. Thank you, and good luck.